Slide 1. Electrophysiology of the Heart is a series of slide tape programs developed and produced by the American Physiological Society. This is Disorders of Cardiac Rhythm, Part 2. Content expert, Dr. Rory W. Childers. 2. The earlier programs in this series present discussions of basic membrane physiology, cardiac cellular electrophysiology, and the electrical anatomy of the heart. The programs that follow present discussions of electrocardiography fundamental theory and electrocardiography applied theory. 3. This program continues the discussion of the electrophysiological basis of common disorders of rhythm. In Part 1, we discussed the disorders of rhythm due to abnormal impulse propagation, which is largely concerned with heart block. 4. The commonest disturbance of cardiac rhythm is ectopic impulse formation, in which the heartbeat is generated in tissue other than the sinus node. The effects of ectopic impulse formation and the functional anatomy of reentrant excitation are the subjects of this program. Your understanding of the concepts presented in the earlier programs in this series is important to your successful completion of this program. A brief test of these concepts begins on the next slide. 5. This is an example of a normal ECG. Sketch two comparable ECGs, one showing first-degree AV nodal block and one showing third-degree AV nodal block. What are the three common locations for heart block? Please stop the tape while you answer these questions and those that follow throughout the program. Restart the tape to check your answers. 6. In first-degree block, the ECG shows simple delay of conduction. In third-degree block, no impulse conduction is seen after the block occurs. Heart block commonly occurs in the sinoatrial node, the atrioventricular node, and in the bundle branches. 7. This is a classical 5-4 AV nodal Wenck-Bach second-degree block. Sketch a 4-3 AV nodal Wenck-Bach block. Describe the three characteristics of the distal event. 8. A 4-3 AV nodal Wenck-Bach block shows 4 proximal electrical events in the atria and 3 distal events in the ventricles prior to the dropped beat. Characteristically, the PR intervals of the distal event shorten progressively and are followed by a pause. The first cycle following the pause is longer than that which precedes the pause, and the sum of any two cycles exceeds the pause. 9. Sketch and label a diagram of the comparative durations of the refractory periods of the atrium, AV node, bundle branches, and ventricular muscle. The duration of the His bundle is given. 10. These are the comparative refractory periods. Note the alternating durations between contiguous tissues. 11. Your first objective is to be able to describe the two types of ectopic impulses. 12. Ectopic beats are due to either ectopic automaticity in the escape system or to reentrant excitation. There are other possible mechanisms, but they are beyond the scope of this discussion. 13. Ectopic beats may occur singly or continuously. Here are two examples: a single ventricular escape beat following a type 2 second-degree block, and a reentrant ventricular tachycardia. 14. Any ectopic impulse seeks to penetrate all the electrical tissues of the heart by both retrograde and antegrade conduction. The success or failure of this penetration profoundly influences subsequent events. 15. To briefly review our earlier discussion of escape beats, recall that when a pause in sinus rhythm exceeds the escape interval of an ectopic pacemaker, an escape beat may occur, terminating the pause. Such escape beats are formed by pacemaker activity in a single cell and appear late in diastole. If the sinus rate falls below that of an ectopic pacemaker in the escape system, an escape rhythm may be sustained. 16. Recall also that an accelerated escape center may usurp the sinus node if the escape center has a faster rate than the node. In this example, the junctional rate is accelerated beyond the basic sinus rate, so the dominant pacemaker of the ventricle is the junction. Since the atrium remains under sinus control, atrioventricular dissociation is present. Note that in the fourth beat, the P wave is submerged in the QRS. 17. In contrast to ectopic escape beats, single or sequential reentrant beats are formed by a loop or circus movement of an impulse within a geometric unit of cardiac tissue. 18. Atrial and ventricular premature beats may be expressions of reentrant excitation. Notice that reentrant beats typically occur early in the sinus cycle. The remainder of this program discusses the detailed events subsequent to atrial and ventricular premature beats and the functional anatomy of reentrant excitation. 19. There are two major differences between escape and reentrant ectopic beats. First, what is the origin of the impulse that generates each kind of ectopic beat? Second, what is the position in time of each kind of beat? 20. An ectopic escape beat generates its own impulse and occurs late in diastole, terminating a pause. A reentrant beat or impulse derives from the previous beat and is typically early in the sinus cycle. 21. Your next objective is to be able to describe the features of an atrial premature impulse, to derive the relevant ECG by examination of the action potentials of the premature impulse recorded in various cardiac tissues, and to state what interval manipulation you would perform to change the QRS of the atrial premature beat. 22. In an atrial premature beat, activation of the atria is abnormal. The beat has three distinctive features in the ECG. First, the ectopic P wave differs in shape from the sinus P wave. Second, the premature beat comes early in the sinus cycle, frequently interrupting the contour of the ST segment or T wave. 23. Third, by penetrating the sinus node, the premature beat resets the sequence of automaticity. The returning cycle is generally longer than the basic sinus cycle, a function of the time taken for the ectopic impulse to enter the node. 24. This is a comparison of atrial action potentials and their corresponding ECG. The fate of the atrial premature impulse, A2, depends on two factors: the previous atrial cycle length, A1, and the coupling interval, A1, A2. 25. The first factor, previous cycle length, determines the durations of the absolute and relative refractory barriers in the AV node and bundle branches. Recall that when the preceding cycle length is long, the bundle branches, especially the right bundle branch, have the longest refractory periods. When the previous cycle length is short, the AV node generally has the longest refractory period. It should be mentioned that autonomic nerve traffic in the AV node is also a determining factor in the duration of its refractory period. 26. Also recall that in the AV node, the duration of refractoriness lags beyond that of the action potential, whereas in the bundle branches and most other cardiac tissues, the duration of refractoriness corresponds precisely with the duration of the action potential. 27. In this example, two sinus beats are followed by an atrial premature beat. The responses to these three impulses are recorded in various tissues as action potentials. The atrial premature beat, A2, is clearly confronting the AV node during its absolute refractory period. The premature impulse is extinguished close to the high AV nodal recording site, which shows only a hump instead of an action potential. In the ECG, the shape of the premature atrial P wave differs from that of the sinus P wave. 28. In this instance, the A1 cycle length is longer. The premature impulse, A2', having traversed the AV node with some delay, confronts the absolute zone of the right bundle branch refractory period and fails to evoke an action potential therein. Assuming that the left bundle branch conduction is normal, the ECG shows QRS widening and change in shape because of the physiological right bundle branch block. The QRS widening is due to asynchronous ventricular activation. 29. The second factor determining the fate of the atrial premature impulse is the coupling interval. In this example, the cycle length is the same as in the previous slide, but the coupling interval, A1-A2, has been shortened. Notice the successful passage of the A2 impulse through the AV node and the right bundle branch, and the generation of a normal QRS following the prolonged PR interval. The explanation for this is shown in the next slide. 30. In this diagram of refractory periods, both premature beats encounter delay in the relative refractory period of the AV node. A2' confronts the absolute refractory period of the right bundle branch and is blocked. The intranodal delay of A2, however, is so great that the impulse reaches the right bundle branch after it is fully recovered from refractoriness. 31. Thus, with an increasing degree of prematurity of the A2 impulse, the following series of events can occur. PR and QRS normal, PR normal or slightly prolonged with QRS widened by physiologic right bundle branch block, PR excessively long with QRS normal, or premature beat not conducted, hence no QRS. 32. Keeping the same A1-A2 interval, how would you change the sinus cycle, that is, the A1-A1 interval, to permit successful passage of A2 through the right bundle branch? 33. Shortening the sinus cycle shortens the action potential of the right bundle branch and allows successful passage of A2. 34. As your second objective, you should be able to describe the possible events subsequent to a ventricular premature beat. 35. In a ventricular premature beat, the activation of the ventricle is abnormal and asynchronous. The impulse spreads from the ventricle of origin across the ventricular septum to the opposite ventricle. 36. In the electrocardiogram, the premature ventricular beat appears as an early QRS and is completely different in shape from that generated by a sinus impulse. The duration of the premature beat's QRS is at least 0.12 seconds long, compared to the normal QRS of 0.08 seconds. The premature beat is almost always followed by a pause. 37. Wherever possible, the ventricular premature impulse seeks to ascend, by retrograde conduction, the bundle branches, His bundle, AV node, atrium, and sinus node. The success of retrograde conduction is dependent on the temporal position of the premature impulse with respect to sinus rhythm. 38. When conditions are ideal, the ventricular premature impulse travels to the atrium and sinus node, producing a retrograde P wave and resetting the sequence of sinus automaticity with a returning cycle. Thus, the retrograde P has the same effect on the sinus node as an atrial premature beat. 39. Retrograde conduction of the impulse through the bundle branches, His bundle, AV node, atrium, and sinus node is not successful if the sinus impulse reaches any of these structures first, producing a collision. 40. Neither is retrograde conduction successful if the prematurity of the ventricular ectopic impulse causes it to challenge any of these tissues during its refractory period. In this example, the impulse fails to ascend the refractory bundle branches. 41. Depending on the prematurity of the ventricular impulse, the sinus P wave may precede, be submerged in, or follow the QRS of the ventricular premature beat. In the bottom strip, the trailing sinus P fails to conduct because the AV node was rendered absolutely refractory by the retrograde penetration of the ventricular premature impulse. 42. This tracing demonstrates an important aspect of cardiac arrhythmia, concealed conduction. The ventricular premature beat penetrates but does not traverse the AV node. The subsequent sinus beat finds the node relatively refractory due to this penetration. Hence, the PR is prolonged. The conduction of an impulse is said to be concealed if it is revealed only by its effect on the transmission of a subsequent beat. The only evidence of retrograde AV nodal penetration here is PR prolongation of the subsequent sinus beat. 43. There is a circumstance in which the ventricular premature impulse can reach the atrium without disturbing sinus rhythm. In this tracing, the P wave is created by the colliding atrial wave fronts of both the retrograde and sinus impulses. This is a fusion P wave. 44. When, under unusual circumstances, a ventricular premature beat is initiated on the apex of the preceding T wave, ventricular fibrillation may result. The muscle wiggles and twitches instead of contracting in an organized pattern. No blood is pumped, and the patient will die of brain damage within 5 minutes unless the fibrillation is immediately reversed by high-energy transthoracic electrical shock. This is a common complication of heart attacks. 45. The vulnerability of the ventricle at the apex of the T wave may be a reflection of the inhomogeneity of refractoriness during repolarization. One portion of the myocardium is absolutely refractory and remains unexcited by the premature impulse, while the remaining myocardium is relatively refractory and is excited by the slowly progressing impulse. This disparity causes multiple reentrant circuits, and complete electrical disorganization ensues. Reentrant circuits are discussed in detail in the next section. 46. In this tracing, the basic rhythm is junctional with retrograde conduction to the atrium. Explain why the retrograde RP interval expands following the ventricular ectopic beat. Explain why the subsequent junctional beat fails to come on time, indicated by the arrow. 47. The RP interval expands because the ventricular premature beat enters the AV node when it is still relatively refractory from the previous retrograde junctional impulse. Conduction to the atrium is therefore delayed. During its passage to the atrium, the retrograde ventricular impulse resets the junctional pacemaker, displacing the subsequent junctional beat. 48. Your last objective is to be able to describe the mechanism of reentrant excitation. State the causes of failure in attempted reentry, and state the factors that determine the rate of reentrant tachycardias. 49. In reentrant excitation, conduction of the cardiac impulse is blocked in a tissue element that is normally used in propagation. We will call this element beta. The impulse proceeds from an initial common pathway, ICP, through a neighboring tissue element, alpha, to a final confluence, FC. This asymmetric event is called longitudinal dissociation. 50. The impulse then enters the unused element, beta, and traverses it slowly in the retrograde direction. 51. If retrograde conduction is slow in beta and the total circuit time, alpha plus beta, exceeds the absolute refractory period of the initial common pathway, the retrograde impulse re-enters the initial common pathway and forms a second beat. In this example, the block in beta is said to be unidirectional. 52. Or, if circuit time exceeds the refractory period of alpha, the impulse re-enters alpha and initiates a second beat in the final confluence by antigrade conduction. 53. Unsuccessful attempts at reentrant excitation probably occur frequently and are not evident in the ECG. An impulse cannot re-enter a circuit if it arrives at the initial common pathway while it is still refractory, or if the block in beta is bidirectional, in which case the impulse never returns to the common pathway. 54. Again, the most common manifestations of reentrant excitation are atrial and ventricular premature beats, which have these characteristic appearances in the surface ECG. 55. Although reentrant excitation does not require a branching system, branching systems are available in the pectinate muscles of the atrium. These may constitute the geometry of some atrial premature beats. 56. In the ventricles, the branching system of the Purkinje network may be the site of reentrant excitation. This has been experimentally verified. 57. Consecutively completed loop circuits constitute a paroxysmal tachycardia. The rate of a reentrant tachycardia is a function of the total circuit time of the reentrant loop. This is in turn a function of the actual circumference of the loop, the conduction velocity in each of the component tissue elements, and the refractory period of each component tissue. 58. Paroxysmal reentrant atrial and ventricular tachycardia have this appearance in the surface ECG. 59. The development of a bidirectional block is a frequent reason for spontaneous arrest of a reentrant tachycardia. When conduction in beta deteriorates, the rate slows. When the impulse fails to complete the loop, the tachycardia stops. These changes often can be achieved by drugs. 60. Reentry can also occur in the AV node. These two models of reentry in the AV node differ only with respect to the atrium. Although either model serves to illustrate common expressions of human AV nodal reentry, in man, the atrium need not be an essential component of the reentrant loop. 61. In the AV node, reentrant excitation requires longitudinal dissociation of the alpha and beta pathways. During first-degree block, for example, there is general impairment of conduction within the AV node. This impairment, however, may be unequal. In this case, conduction in beta is then more rapid than in alpha. During the sinus beats, both pathways are traversed effectively. The QRS, however, is produced by the faster beta impulse. 62. During first-degree block, the refractory periods of the two longitudinally dissociated tissue elements are also at variance. Therefore, an atrial premature beat may find the beta tract refractory and use only the slower alpha tract. 63. Upon reaching the final confluence, the alpha impulse finds the unused beta tract open and re-enters the atrium by retrograde conduction, producing an atrial echo with a retrograde P wave. 64. The inhomogeneity of refractoriness in the AV node that leads to longitudinal dissociation can also be elicited by the retrograde impulse of a ventricular premature beat. The reentrant beat is a ventricular echo. 65. In second-degree antegrade AV nodal Wenck-Bach sequences, longitudinal dissociation may occur when conduction is maximally impaired, that is, when the PR interval is at its longest. The reentrant beat is again displayed as an atrial echo and registers as an inverted retrograde P wave. 66. Similarly, longitudinal dissociation may occur when the RP interval is maximal during retrograde nodal Wenck-Bach sequences with a junctional or His bundle pacemaker. The reentrant beat is displayed as a ventricular echo. 67. Reentrant AV nodal tachycardia may be initiated in any of the situations just discussed. When block in the AV node is first degree, either an atrial or ventricular premature impulse may elicit reentrant tachycardia in the node. During the tachycardia, each completed loop circuit gives rise to a retrograde P wave and a QRS. 68. In many cases, the retrograde P is buried in the QRS. That is, the impulses reach the atrium and ventricles simultaneously. 69. Since the atrial premature beat shown in previous slides is often itself a reentrant beat, it may initiate a tachycardia at its own site of origin within the atrium. In such instances, all subsequent P waves are identical and do not show retrograde characteristics. 70. Reentrant atrial tachycardia of this type may show 2-1 AV nodal block, the AV node permitting passage of alternate atrial impulses. 71. Recall that the rate of any reentrant tachycardia is a function of the circumference of the loop and the conduction velocity in each of its component tissues. The conduction velocities are in turn a function of the refractory periods, one or more of which may impose a major limitation on the time it takes to complete a circuit. 72. Clinically, AV nodal tachycardia has the following features. It starts and stops suddenly. It may be arrested by maneuvers that increase vagal nerve traffic to the AV node, which prolongs the refractory period and conduction velocity within the loop, breaking the circuit. You should be aware that in atrial tachycardia, such maneuvers may induce temporary 2-1 or 3-1 AV nodal block without arresting the tachycardia.